Invasive aspergillosis. Introduction. Invasive aspergillosis is being increasingly recognized as an important illness in the ICU. Most affected site is the lungs. Commonest species is Aspergillus fumigatus. Risk factors have been divided into two types. One is the classic or traditional risk factors and the glowing evidence of invasive aspergillosis, the non-classic risk factors. Classic risk factors are the neutropenia, hematologic cancer, hematopoietic stem cell transplant, solid organ transplant, primary immunodeficiency, HIV or AIDS. The non-classic risk factors are the diabetics, chronic steroid users, liver disease patients, COPD patients, influenza and recent COVID-19. Many of these patients with the non-classic risk factors are admitted to the ICU, in whom the clinical and radiologic features are non-specific. Positive cultures are often considered colonization and index of suspicion is low, leading to delayed diagnosis with consequent high mortality. Hence, critical care specialists should always keep a low threshold for diagnosing invasive aspergillosis in the ICU and in those with non-classic risk factors. Epidemiology. A review of invasive aspergillosis in ICU shows prevalence between 0.7 to 19%. Autopsy studies have placed invasive aspergillosis as one of the most common misdiagnoses in patients dying in the ICU. Pathogenesis. Patients with sepsis and multi-organ dysfunction have biphasic response with an initial hyperimmune response and then a state of immunoparalysis where depression of neutrophilic function happens, which leads to invasive disease. Damage to the respiratory epithelium due to mechanical ventilation is also contributory. In patients with neutropenia, the organism burden is high with dissemination to various organs. Conversely, in non-neutropenic patients with non-traditional risk factors, it is believed that the damage is partly due to host immune response with low fungal burden and disease mainly confined to the lungs. Clinical features. The clinical features depend on the site of involvement and are non-specific. It is sometimes difficult to separate the features of invasive aspergillosis from the underlying disease, example influenza, COVID or COPD, or from other super or co-infections such as bacteria, candida and other molds, and non-infective complications in the critically ill. It is often difficult to elicit symptoms and signs in critically ill patients who may be ventilated and sedated. Fever is neither specific nor sensitive. Presence of cough with expectoration, chest pain, pleural rub, hemoptysis, increased ventilatory requirements are seen in invasive pulmonary aspergillosis. CNS disease manifests as encephalopathy, seizures or focal deficit. Other manifestations include endocarditis, graft infections, mediastinitis, etc. Progression despite adequate treatment of underlying disease and non-response to appropriately chosen antibiotics are subtle clues to the diagnosis of invasive aspergillosis. Radiology. The computerized tomographic scan of the chest is more sensitive and specific than the chest X-ray and hence is the preferred investigation for diagnosis of invasive pulmonary aspergillosis. However, there may be issues in transporting sick patients on high mechanical ventilatory support to the CT unit. While patients with classical risk factors and those with neutropenia show characteristic changes on CT such as nodules with surrounding halo, cavitation and air crescent sign, radiologic findings in those with non-classic risk factors are consolidations, infiltrates and effusions. For diagnosis of CNS disease, MRI brain appears to be the exam of choice and would require at least T1 weighted, T2 weighted FLAIR diffusion weighted imaging after gadolinium injection sequences. Invasive aspergillosis usually presents as a contrast enhancing lesions, sometimes with hemorrhage within the lesions. Filling of the respiratory tract. Since the clinical and radiologic diagnosis is difficult, definitive diagnosis rests on mycologic investigations in respiratory tract specimen. Bronchoscopy or bronchoalveolar lavage is the preferred procedure or specimen. However, it may not always be possible due to logistic reasons, bleeding risk, high ventilator requirements and risk of aerosol generation as with COVID-19. When possible, bronchoalveolar lavage should be performed and sent for galactomannan, fungal culture among other investigations. Transbronchial biopsy should be done if possible. The presence of mucosal lesions on bronchoscopy can be seen in patients with influenza. These lesions should be biopsied and subjected to histopathology and fungal culture. The other respiratory tract specimens include sputum, endotracheal tube aspirate and non-directed bronchoalveolar lavage. Microbiological investigations. Number one is the cultures. While positive cultures from sterile site or tissue confirm the diagnosis of invasive pulmonary aspergillosis. Cultures from non-sterile sites including sputum, endotracheal aspirate, bronchoalveolar lavage may represent colonization rather than infection. Here again the specificity of the cultures from bronchoalveolar lavage is higher than sputum or endotracheal aspirate. At risk patients in the ICU with positive aspergillus cultures from the respiratory tract should be investigated further to establish or exclude the diagnosis of invasive pulmonary aspergillosis. At the same time, patients with invasive pulmonary aspergillosis may have negative cultures. If the culture is deemed clinically significant, susceptibility test should be done. Biomarkers. Serum galactomannan is very useful in neutropenic cancer or stem cell transplant patients with sensitivity and specificity exceeding 85%. However, the sensitivity of serum galactomannan in non-neutropenic patients is poor, ranging anywhere from 20 to 70%. Prior admission of amoxicillin clavulanate or piperacillin tazobactam may also result in false positive galactomannan. The sensitivity of BAL galactomannan is significantly higher than serum galactomannan in the critically ill patient and approaches 80%. Most centers use a cutoff of 0.8 to 1 for a positive test. A value of less than 0.5 has high negative predictive value for invasive pulmonary aspergillosis, while a cutoff of more than 3 has a very high specificity and high positive predictive value. Serum 1,3-beta-D-glucan is commonly used to confirm or exclude the diagnosis of invasive candidiasis. Apart from candidiasis, 1,3-beta-D-glucan is also produced by aspergillus. It can be also positive in other situations including severe bacterial infections. Estimation of 1,3-beta-D-glucan along with serum galactomannan improves the sensitivity for diagnosis of invasive aspergillosis as compared to galactomannan alone. Novel diagnostic strategies. A big drawback of the biomarkers are high turnaround time, and as the most laboratories in India batch samples and do not run these assays daily. The aspergillus specific lateral flow assay is the point of care diagnostic test to detect galactomannan in serum, BAL with promising results in preliminary studies, yet it is unavailable in India. Aspergillus PCR testing in blood, biopsy tissue and bronchoalveolar lavage is increasingly being evaluated in screening immunocompromised patients for invasive aspergillosis. However, the role in patients in the intensive care unit is not yet defined. Diagnostic criteria. The diagnosis of invasive aspergillosis is based on clinical, radiologic and mycologic criteria. The EORTC MSG criteria have been used since more than a decade for diagnosing invasive aspergillosis in immunocompromised patients, and it classifies invasive aspergillosis into proven, probable and possible invasive aspergillosis. Proven invasive aspergillosis is when there is histopathologic or culture evidence from sterile sample site. Probable invasive aspergillosis is when host criteria with radiologic criteria and mycologic criteria are all met. These criteria have found to be inadequate for patients with the non-classic risk factors for which other criteria have been proposed. It has been discussed later. Blott et al. Have proposed criteria for invasive pulmonary aspergillosis in critically ill patients known as the ASPERGILLOSIS criteria. The criteria were a positive culture of aspergillus from lower respiratory tract, clinical features, imaging findings and host factors. All the four should be met. Subsequently, the criteria were modified to include galactomannan estimation, which is the modified ASPERGILLOSIS criteria. This is the EORTC MSG criteria, which has been divided into the host criteria, clinical criteria, mycological criteria and proof of invasion. Immunosuppressive conditions such as hematologic cancer, transplantation, treatment with immune modulating agents fulfill the host criteria. Clinical criteria include the suggestive radiological pattern, example nodule, mass, plus minus halo sign, error crescent sign, etc. If both these criteria are met, then it is possible invasive aspergillosis. The mycological criteria is the positive direct exam or culture in non-sterile sites such as bronchoalveolar lavage, bronchial aspirate or sputum, or positive galactomannan and or PCR, if the host criteria, clinical criteria and mycological criteria is met, then we call it probable invasive aspergillosis. And the proof of invasion such as positive histopathology plus minus PCR, direct exam or cultures in sterile sites, e.g. lung biopsy or pleural fluid, and evidence of infection which is given by the histological, radiological or clinical criteria, if this is met, then it is called proven invasive aspergillosis. This is the blot et al. Criteria of ASPICU criteria for aspergillus positive endotracheal aspirate aron. More than one criteria among aspergillus positive endotracheal aspirate compatible clinical signs. Here they have given the definition as putative invasive aspergillosis, probable and proven. The abnormal thoracic medical imaging on CT scan or X-ray, host risk factors or semi-quantitative aspergillus positive culture of bowel fluid plus positive direct microscopy with positive histopathology is the proven invasive aspergillosis. The ASPICU algorithm incorporating the PCR, the aspergillus positive culture or PCR endotracheal aspirate alone, greater than one criterion among the aspergillus positive culture, PCR endotracheal aspirate, compatible clinical signs, abnormal thoracic medical imaging on CT scan or X-ray, host risk factors or semi-quantitative aspergillus positive culture, PCR of bowel fluid plus positive direct microscopy. The definition of probable invasive aspergillosis is the putative invasive aspergillosis plus one positive blood biomarker which is given in the modified ASPICU algorithm. One positive blood biomarker such as galactomannan and or PCR is suggestive of probable invasive aspergillosis, and proven invasive aspergillosis is probable invasive aspergillosis with positive galactomannan, then we call it as positive histopathology, then we call it as proven invasive aspergillosis. The treatment, the empiric antifungal therapy should be started in patients without delaying for the results of diagnostic investigation. Delay in the antifungal therapy worsens the outcomes. Three classes of drugs are available for treatment of invasive aspergillosis. The three classes of drugs are the azoles, which are the voriconazole, itraconazole, posaconazole and isavuconazole, amphotericin B and echinocandins. The current drug of choice is voriconazole, preferably given IV at least initially in critically ill patients. The IV formulation of voriconazole should be avoided in patients with creatinine clearance less than 30 ml per minute because of accumulation of cyclodextrin carrier. If it is given orally, it should be given in empty stomach for better bioavailability. The drug should be used carefully in patients with liver dysfunction. Since the drug is also a cytochrome P450 inhibitor, it can dangerously interact with many other drugs being administered to critically ill patients. QT prolongation is also an undesirable side effect of voriconazole. The other side effects includes liver dysfunction, visual hallucination and skin rash. Since the metabolism of the drug differs from patients, trough levels of the drug should be estimated after day 7. Acceptable trough levels range from 2 to 6 microgram per milliliter. Isavuconazole is the new drug which has been approved as the first line drug for invasive aspergillosis. In head-to-head RCTs, it is proven to be non-inferior to voriconazole for management of invasive aspergillosis with a superior safety profile. Since it covers mucorals, it is preferred when identification of the mold is pending or uncertain. This drug has fewer side effects including QT prolongation, fewer drug interactions and better or predictable bioavailability as compared to voriconazole. Therapeutic drug monitoring is not required with isavuconazole. It is available as oral and IV formulations. The dose does not need to be adjusted in renal or hepatic dysfunction. It is several times more expensive than voriconazole. However, the CNS penetration of the drug is poor. It is indicated when voriconazole cannot be given or is not tolerated. The dose is 200 mg thrice daily for 2 days and then once daily. Posaconazole is another broad spectrum azole which covers both aspergillus and mucorales. It has been used in salvage therapy for invasive aspergillosis. While the suspension had poor and unpredictable bioavailability, the intravenous and gastric acid resistant oral formulation have good bioavailability. The side effects and drug interactions are lower than with voriconazole. It may be used for patients with invasive aspergillosis who cannot tolerate voriconazole, or when the identification of the mold is uncertain, or when isavuconazole is unaffordable or unavailable. Itraconazole is not recommended in critically ill patients because of its poor bioavailability, especially of the capsule formulation. Liposomal amphotericin B is dosed as 3 mg per kg per day as an alternative for treatment of invasive aspergillosis. It has inferior efficacy as compared to voriconazole. Nephrotoxicity and dyselectrolytemia are limiting factors with liposomal amphotericin B. Liposomal amphotericin B may also be used if the mold infection is uncertain and if none of the azoles can be given or azole resistance is suspected or proven. The echinocandins have fair activity against aspergillus, are safer than voriconazole and liposomal amphotericin B in the setting of renal or hepatic dysfunction and critical illness. While only caspofungin has been approved for the treatment of invasive aspergillosis, other echinocandins are often used in clinical practice. Anidulafungin is the preferred in setting of hepatic dysfunction. The echinocandin should be used only if other drugs which are discussed above cannot be given, or when identity of the invasive fungal infection is uncertain, or as a salvage therapy. The combination of voriconazole and anidulafungin can be used as a salvage therapy. The duration of the therapy has not been clearly defined, but generally ranges from 4 to 8 weeks or until clinical and radiological resolution of the disease. Sir, book. Sir, infectious disease in critical care medicine by Atul Kulkarni. না স্যার এইটার তো এটা মানে স্যার এইটার অ্যালাইনমেন্টটা স্যার এ হয়ে গেছে, বাকিগুলো স্যার ঠিকই আছে, এইটার অ্যালাইনমেন্টটা স্যার ঠিক হয়ে গেছে।
But textটাকে directly এতটা তুলে ধরাটা is not a nice presentation. So you can summarize it, press it, make 4, 5, 6 bullet points and put it, but not এতটা ঘন text
Prevention of invasive aspergillosis involves avoidance of construction activity in the vicinity of the ICU. Use of high efficiency particulate filters reduces the incidence of invasive aspergillosis but does not bring invasive aspergillosis down to zero. Restriction or limitation of corticosteroid use in the critically ill is also recommended. Patients who merit mold active prophylaxis are those with HSCT recipients, myelodysplastic syndrome, recurrent acute leukemia and aplastic anemia. Options include posaconazole, mycofungin, voriconazole, nebulized amphotericin B and intermittent therapy with liposomal amphotericin B. There is no current drug approved for prophylaxis in non-neutropenic patients. Thanks. Sir.
Clinical suspicion. What are the risk factors?
Sir, risk factors are the classical risk factors and which are the growing evidence of infection, growing evidence of invasive aspergillosis which has been found in patients with diabetes, steroid use, and the classical risk factors are the ones patients who have hematologic malignancies, who have undergone hematopoietic stem cells transplant, acute leukemias. These are the classic risk factors.
You have covered invasive aspergillosis.
Sir, topics to our invasive aspergillosis.
So the problem is that if you have a very high pre-test probability, our clinical scenario is a hematology patient who's neutropenic or a bone marrow transplant patient, not yet fully recovered, etc. ওখানে সবার মাথায় aspergillosis থাকে, ঠিক আছে? ওই সিচুয়েশনে ওরা prophylaxis with that, and surprisingly the problem it is apparently prophylaxis aid, it does have work. And aspergillosis is present all around us. Confirming the diagnosis is very difficult. Either because getting samples is difficult, the patients are sick and neutropenic, they're also thrombocytopenic, bleed করে, respiratory involvement হলে hypoxic থাকে, ventilated থাকে, biopsy নেওয়া difficult. শুধু মানে aspirate বা এটাতে aspergillus really doesn't confirm the diagnosis. In fact, in such circumstances, radiology helps a lot. So, generally people think about aspergillus, and if you think about aspergillus in that sort of a hematology situation, you are better off treating because the mortality etc. is otherwise very high. এখন প্রবলেম যেটা হয়েছে এই যে নন ক্লাসিক্যাল সিচুয়েশনস আর আমরা যে দেখি এই নট আ পেশেন্ট সিওপিডি দ্বারা মানে প্রত্যেক 2-3 মাস অন্তর অন্তর স্টেরয়েড পাচ্ছে, বাই দ্য টাইম দ্য স্টেরয়েড ইজ টেইল অফ আবার একটা স্টেরয়েড কোর্স চালু হয়ে গেছে, ইনহেলড ড্রাগসও অনেক পাচ্ছে, সাম অফ দেম আর অলসো ডায়াবেটিক, they come with not that sort of invasive aspergillosis, but they come with like a pneumonia যেটা তোমার রিজলভ করছে না, নেক্রোজ করছে, তুমি হয়তো ভাবছো malignancy, ওখানে চট করে আমরা aspergillosis-এর কথা ভাবছি না. There we have been surprised by finding aspergillus. Then you are perhaps able to do some more tests etc. And then the serology and the BAL galactomannan, which is better than serum, is useful. Ekhane imaging is not that helpful because there will be signs.
Sir, halo sign or crescent sign?
They are more for invasive aspergillosis. Neutropenic patient, they not become very chronic necrotizing pulmonary aspergillosis. That looks like a bad necrotizing pneumonia patient is very sick. And once you have given your antibiotics, you're thinking about malignancy, you've done a biopsy or a bronchoscopy, there you might get a clue, then you throw in your aspergillus treatment.
The more common one is the allergy.
Yeah, but those are more of an OPD sort of patient. There are two other problems which are caused by aspergillus. One is an allergic bronchopulmonary aspergillosis, which is an allergic disorder. There the patient is presenting to you with asthma-like symptoms, and you
IG level টা বেড়ে যায় স্যার।
হ্যাঁ, total IgE বাড়বে, আর allergic aspergillus specific IgE বা respiratory বা skin testও বাড়বে, eosinophilia থাকে, central থাকে, আর এই স্পুটামে ব্ল্যাক lumps থাকে যেখানে aspergillus পাওয়া যায়. It's not a difficult diagnosis to make in the appropriate patient, but they present with breathlessness, pulmonary infiltrates, etc. And paradoxically, the treatment is steroids because it is more of a IgE-mediated allergic hamster reaction. And অন্যটা যেটা classical exam ছবি দেয় is the aspergillus, যেটা হচ্ছে aspergillus ball, which is more of a saprophytic sort of situation. যেটা pre-existing cavity আছে, ওখানে একটা ঘর করে পড়ে আছে, ওটা করে invade করে না, but it can present with life-threatening bleed. So then you have to treat that. Now, I mean, if it's a life-threatening bleed, then you might have to do embolization surgery, etc. Otherwise, sometimes they do have some low-grade cough. So you give long-term antifungal. There, itraconazole is more commonly used. But the group that troubles is the second group, non-classical, and ওখানে suspicion-টা চট করে হয় না, তখন
প্লাস স্যার আইসিইউতে যে পেশেন্টগুলো থাকে সেডেটেড মেকানিক্যালি ভেন্টিলেটেড থাকে, ওগুলোতে ধরাও মুশকিল হয়ে যায়।
প্রফেসরি করা আছে আর আওয়াজে পাওয়া মানে যে তাহলে কিন্তু ওই প্রবাবিলিটি গুলো পাই। Once it sort of hits you, then it becomes a little bit easier. And if you've got a reasonably high pre-test probability that this patient is susceptible, then it is better to treat it.
4 to 8 weeks.
Yeah.
IV intravenous.
Sir, time patches.
Drug of choice now is
Body.
So that is available as oral. It's better to give it oral.
ঘড়ির আপনার যে সাইড এফেক্টগুলো আছে যেমন লিভার ডিসফাংশন, কিউটি প্রলঙ্গেশন, ওইগুলো আপনার ইসাবুকোনাজোলটা ওটাতে এলিমিনেট করা যায়, সেটা ইউজ করতে পারি। আর না হলে স্যার পোসাকোনাজোল বা কম্বিনেশন স্যার ক্যাসপো মানে একাইনোক্যান্ডিনের সাথে কম্বিনেশন করে দেওয়া যেতে পারে। স্যার আইভি তো বেটার। Sir, hepatic dysfunction, creatinine.
What is your presentation? You have mentioned. What does it contain?
Side effects.
What does it contain which can cause problems with renal function?
7th finger. Intravenous one.
Sir, cyclodextrin.
So we recently went through this pandemic COVID. So after that, a new term was coined COVID associated pulmonary aspergillosis. So any difference in the diagnostic criteria that apart from other invasive aspergillosis?
Depends on if you're working in a hospital with the hematology unit active bone marrow transplant. So here, we have seen some patients with suspect large hands. If you suspect, you throw it. By the time I'm asked to see, they're already all on foreign colors, all that everything. So yeah, I proven as in with all those fancy tests, but we don't get to do all the fancy tests all the time, and most of the patients actually